Assalamualaikum and good morning. I would like to thank the organizer, Malaysian Society of Infection Control and Infectious Disease, as well as NIH, for inviting me to this seminar and for giving me the opportunity to talk about management of dengue in primary care. My name is Dr. Fazlina. I am a family medicine specialist in Klinik Kesihatan Anika, Klang. Dengue is one of the most important arthropod-borne viral diseases with high morbidity and mortality. It affects tropical and subtropical regions around the world, predominantly in urban areas. This is the CPG management of dengue infection in adult 3rd edition 2015. This is the latest CPG so far and should have a new one soon. We have here a 20-year-old man with no known medical illness. He came with a complaint of fever for 5 days, joint pain for 2 days, and he was living in a dengue area where there was a fogging at his house last week. He had no warning signs. On examination, he was pink. Temperature was 37.6. BP was 120/70 and pulse rate was 90 beats per minute. All other systemic examinations were normal. Investigation showed that his WBC was 2.8, HB was 12, platelet was 110, and hematocrit was 38. His dengue combo test NS1 was positive, IgG and IgM was negative. So this is one of the among so many dengue cases in Malaysia. In Malaysia, dengue cases and incidence rate has been increasing from year 2000 but somehow decreased by 17% in the year 2017. The trend tends to increase back in 2019. During COVID pandemic 2021, there is further drop of dengue by 74% compared to the dengue cases in 2020. At the end of 2021, there were about 26,000 cases of dengue with 20 deaths. There were 2 peaks of dengue trend in Malaysia throughout 10 years, where they peaked in 2015 and 2019. It is postulated that the dengue will increase back in 2023. Thus, we need to be ready to curb this peak. This graph shows that early in 2013, there were 4 serotypes of dengue, but over the years, serotype 2 and 3 has been predominant, and serotype 4 has been markedly decreased. So, how to diagnose dengue? Dengue is diagnosed using WHO criteria 2009. That is fever plus 2 other symptoms. The 2 other symptoms could be nausea, vomiting, rashes, itches and pain, leukopenia or any warning sign. We define dengue disease severity using WHO criteria 2009. That is dengue with or without warning signs or severe dengue. Patient with severe dengue could have severe plasma leakage or severe hemorrhage or severe organ impairment. We manage dengue cases by using 3 stepwise approaches. The step 1 is overall assessment and we are taking the history. The clinical course of dengue infection has 3 phases. First, the patient will go into febrile phase, and then the patient will go into critical phase, and lastly, the patient will go into recovery phase. When patient got dengue, they usually start with febrile phase, which usually lasts for 2 to 7 days. And then, patient will go into critical phase, where it usually occurs at the 3rd day of fever. The clinical presentation will depend on the presence and degree of plasma leakage, but this critical phase usually lasts for about 24 to 48 hours. If the patient survives, the patient may go into recovery phase. In severe dengue, during this phase, the plasma leakage will stop and is followed by reabsorption of extravascular fluid. Dengue infection is actually a dynamic disease, and the clinical course will change as the disease progresses. After history, we will go to physical examination. In physical examination, first we will assess the patient's mental state and GCS, and then we will assess the patient's hydration, followed by assessing the patient's hemodynamic. A quick way of assessing hemodynamic is by using CCTVR. The CCTVR is one of the signs to indicate severe dengue. It is called a magic touch. Holding the patient's hand is a quick way to evaluate the peripheral perfusion. In less than 30 seconds, you can tell whether the peripheral perfusion is normal or reduced or very reduced. First, we look at the patient's skin color, whether it is pale or pink. Touch the patients to assess the capillary refill time, whether it is delayed or normal. Feel for the patient's temperature, for warm or cold and clammy. Find the patient's pulse volume, whether it is normal, weak or trendy. Count the patient's pulse rate, whether it is normal, tachy or brady. The picture at the left shows how we want to assess the capillary refill time. First, we have to press the patient's skin and then lift the finger. Then we count how many seconds it takes for the skin to become pink again. If it is less than 2 seconds, it is normal. Then we have to check the patient's BP and pulse pressure. Patient with dengue can go into hypovolemic shock. When patient is having compensated shock, the BP is still normal, but the heart rate will start to increase more than 100. And then, if the patient go into decompensated shock, the BP will start to drop and the pulse pressure will become narrow. Other systemic examination, we have to look out for tachypnea and also pleural effusion. Check for abdominal tenderness or any hepatomegaly or ascites. Other than that, we can also examine for bleeding manifestation. What are the investigations that we need to do for dengue? Full blood count is a very important investigation to be done. In dengue, we will see the decrease in WBC and platelet. However, there is no correlation between disease severity and platelet count, and it is not a predictive of bleeding. In recovery phase, the WBC will normalize, followed by platelet. A rising of hematocrit is a marker of plasma leakage in dengue infection. We need to know the normal value of hematocrit to compare with the patient. In dengue, we need to monitor the full blood count and hematocrit as the dengue infection progresses. The next investigation is a diagnostic test. Rapid combo test consists of dengue NS1 antigen and dengue IgM and IgG antibodies. NS1 antigen will usually become positive at 4 to 5 days of illness onwards and will become negative at recovery phase. A positive test usually indicates that the patient is having acute dengue infection. If it is present after 5 days, it may predict severe dengue. For IgM test, it is usually positive after day 5 to 7 of illness, and a positive test usually will suggest that the patient is having recent dengue infection. For IgG test, it is usually positive after day 7 of onset of fever, and a positive test will suggest that the patient is having acute or past infections. A titer of 1 in 2000 is consistent with acute secondary infection. The other test is dengue viral RNA detection. which is useful for determination of circulating dengue serotypes in the country. Step 2. Diagnosis, disease staging and severity assessment. These 5 points should be included in dengue diagnosis. For example, for the case that we illustrate earlier, the complete diagnosis will be dengue fever day 5 in a febrile phase without warning signs, patient is not in shock, and patient is not having severe dengue. Step 3 is plan of management. Not all dengue cases need to be hospitalized. The patient can be treated at home if the patient are able to tolerate orally well, has good urine output and no history of bleeding, has absence of warning signs, physical examinations all normal, investigation shows stable serial hematocrit, and no other criteria of admissions like the patient doesn't have any comorbidities, the patients are not pregnant or doesn't have any social factors. Patient can be sent home with symptomatic and supportive treatment. However, patient needs to do daily or more frequent follow-up if necessary from day 3 onwards until afebrile for at least 24 to 48 hours without any antipyretics. The doctor needs to use dengue clerking sheet to clerk the patient, and the patient should be provided with outpatient dengue monitoring records and home care advice leaflets, and advise the patient to come or return to the hospital as soon as possible if they have any warning signs. This is the dengue monitoring record that is available in primary care. Patient who is diagnosed as dengue will be given this card and need to submit this card to the attending doctor every time they go to the clinic. The doctor can monitor the patient's progress from this card, and the doctor needs to fill in the whole column including the next appointment so that the patient will know when to come back to the clinic. And this is the home care advice leaflet that is given to all dengue patients. In this leaflet, the patient can know what they can do and what they should avoid. And for example, in the avoid part, the patient should not take any NSAIDs, example aspirin, Ponstan or steroids. And the patient should not take any antibiotics or take any injections or do any massage, cupping or kuasa. At the back of the leaflets, there is a danger signs that the patient should monitor, and if let's say they have any of these warning signs, the patient needs to go to the nearest hospital as soon as possible. Patient needs to be admitted if they have warning signs, bleeding manifestations, inability to tolerate oral fluids, reduced urine output or seizure, or if they have dehydration, shock or bleeding or any organ failure. Special group of patients have high risk of getting severe dengue and need to be admitted early if indicated. And this special group of people are patients with comorbidity, for example diabetic, hypertension, ischemic heart disease, coagulopathy, morbid obesity, renal failure, and so on. Or elderly patients more than 65 years old, patients who are on antiplatelet or anticoagulants, patients who are pregnant, or patients with social factors. Other than that, if the patient has rising hematocrit accompanied by reduced platelet count, this patient also need to be admitted. Fluid is very important in dengue management. For non-shock patients have to increase their oral intake. IV fluid 0.9% saline is recommended in patients with increasing hematocrit with evidence of ongoing plasma leakage despite increase of oral intake. Other than that, if patients are vomiting and having severe diarrhea or cannot tolerate orally, they also need to have IV fluid. When giving IV fluid, we need to calculate the fluid regime. For non-obese patient, fluid is given by 1.2 to 1.5 ml per kg per hour. For obese patient, we have to adjust the body weight first before giving the fluid regime. And patient who is in shock should have given bolus regime and start with 5 ml per kg per hour for 1 to 2 hours, then reduce to 3 ml per kg per hour for another 2 to 4 hours, and then reduce some more to 2 ml per kg per hour or less according to the patient clinical response. When referring the patient, we have to optimize the patient conditions before and during the transfer. The ED, ICU or medical department of the receiving hospital must be informed prior to the transfer. Adequate and essential information must be sent together with the patient that includes the fluid charts, monitoring charts, and investigation results. All dengue cases have to be notified. All suspected and confirmed dengue cases from private or public health facilities must be notified by the attending doctor via telephone, fax, or e-notification to the nearest health office within 24 hours of diagnosis. We notify by using the disease category as dengue fever or dengue hemorrhagic fever. And failure to notify is liable to be compounded under the Prevention and Control Infectious Disease Act 1988, and the compound can be up to 1,000 ringgit. And this is the notification form. Now we have e-notification, which is a real-time web-based system used to notify all notifiable disease based on MOH requirement. All dengue cases will be registered by the respective district health officer after they already verify and also investigate the case. And this is done in e-dengue V2. In primary care, we need to get thorough history taking, and we have to use this dengue assessment checklist so that we won't miss anything. All this information will determine whether the patient can be managed in primary care or to be referred to the hospital. First, we have to get the patient's correct name, IC, phone number, and also address. And then we have to diagnose the dengue. The patient have to fulfill the fever with any two of the symptoms. And then we will look at the patient whether they have any warning sign. If they have any warning signs, they may need to be referred immediately. Special group of patients will have high risk of getting severe dengue, so we have to have low threshold of referring them early. Vital signs and blood investigations are very important to determine the patient's condition. The patient who has severe dengue needs to be referred immediately. And then, correct and complete diagnosis is important to plan the patient's next management. In the management, notification should not be missed, and the patient should be given dengue alert card. Dengue mortality are discussed in the state level, and the common errors at primary care is failure to recognize dengue infection in a febrile patients. So all primary care doctors have to have high index of suspicion in febrile patients who is coming from the dengue areas and any patients with symptoms of dengue. The other common errors at primary care is failure to recognize dengue shock in an afebrile patient. So all primary care doctors should have high index of suspicion for patient who has nausea, vomiting, abdominal pain, and warning sign, and any manifestations of compensated or decompensated shock, and have to look at the hematocrit rather than just platelet alone. Signs or symptoms of warning signs are any abdominal pain or tenderness, persistent vomiting more than 3 times over 24 hours, persistent diarrhea more than 3 times over 24 hours, or any third space fluid accumulation such as ascites, pleural or pericardial effusion, or patient has spontaneous bleeding tendency, or patient are feeling lethargy, restlessness or confused, or any tender liver, or any raised hematocrit with rapid drop of platelet. All these patients should be admitted early. Not all fever is dengue. So dengue can also have differential diagnosis. If the patient presents with fever, the other diagnosis could be influenza, measles, chikungunya, adenovirus, or acute HIV. If patient presents with rashes, it could also be rubella, measles, meningococcal meningitis, chickenpox, drug-induced. Or if patient have diarrhea, it could also be rotavirus or food poisoning. Patients who present with acute abdomen could also be acute appendicitis, acute cholecystitis, perforated bowel, or viral hepatitis. Patient may come in shock, but it could also be septic shock. And patient with respiratory depression, we need to rule out whether this patient is having DKA, acute renal injury, lactate acidosis, or maybe COVID or drug poisoning. And patient who presented with leukopenia and thrombocytopenia and bleeding can also be, other diagnoses can also be malaria, leptospirosis, acute leukemia, TTP or SLE. The challenges that we face in primary care is that the patient may present as atypical and non-specific presentations, and the presentation also can mimic many other diseases, thus will delay the diagnosis. Patient also has other comorbids and have other co-infection, and some patient will even come very late at presentation. So this also can cause acute progression with the multi-organ dysfunctions. We also need regular training on clinical management of dengue to update the healthcare providers, as there are also high turnover of healthcare providers in the health facilities. As a take-home message, in primary care setting, we need to do accurate and prompt diagnosis and notification. All patients should have appropriate monitoring. If the patient can be monitored at home, we need to give them proper patient education and home management. We need to be alert to the dengue warning signs and criteria for admission. And before we transfer the patient, we have to stabilize the patient. Good inter-facility communication and handover is very important in managing dengue. And lastly, there is no prophylaxis for dengue, so prevention is better than cure. Let's fight against dengue by conducting 10-minute search and destroy every week. Number 2, protect yourself against mosquito bite. And number 3, seek early treatment if you have fever and any 2 other symptoms. And in Klinik Kesihatan, we usually give abate to the dengue patients so that they can put this abate into their boiling water. With that, I thank you.